All right, so I put together a quick Part 4 board review for you guys here. It's by no means supposed to be comprehensive or anything like that, but hopefully we'll hit the highlights, cover basically, hopefully all of the conditions you might see pop up on your Part 4 radiology exam. This is just kind of a summary of some of the most common cervical spine conditions, so this would be a good slide to go back to if you want to look stuff up. And so let's just go through some cases. So I just kind of splattered a bunch of cases in here. So we'll just kind of go through and read these together. And when we're going through, it's good to get a sense of a search pattern that you want to use to approach these images. In the cervical spine, I usually recommend starting with the lateral image. It gives you the most information. And I always recommend starting at the atlantodental interval, and then going down and following your line. So do George's line here. Of course, we see there's a spondylolisthesis. That's not what I meant to hit. And so going through and then going vertebral body is facets, posterior elements, and then skipping up here to the spine, or sorry, to the skull, and we can look at our soleoturcica there. That one looks normal, and then making sure we're checking our cervical soft tissue, see if there's anything back here like a nuchal bone, any mass lesions up here anteriorly. Look at our pharyngeal air shadow, which should be close up against. I swear that street cleaner comes by every time I start recording. Make sure that's not enlarged. Make sure our retrotracheal space is normal, right? Our esophagus is back here. Thyroid calcification normal. Don't get tripped up by that. Of course, our hyoid's normal as well. So when we look at this image, this person has RA, so we expect cervical spine involvement. They have a spondy here, which is associated with this facet arthrosis. They've got severe degenerative disc disease kind of throughout. But the main thing here is that anytime we have RA, we're worried about atlantodental instability. So we see flexion extension radiographs here, and then of course, their dens. It's hard to identify here, probably because it's becoming eroded. And then we see their atlantodental interval is substantially increased. So this has moved forward with flexion, even though it was normal on the neutral view. So this is unstable and should have a neurosurgical consult and probably an MRI as well. Here's another example of someone with trauma. And this person traumatically ruptured their ADI, or their transverse ligament, and enlarged their ADI. And so again, this is unstable upper cervical spine. Should probably get an MRI because they have central canal stenosis. I'm just drawing the posterior margin of their central canal from the posterior tubercle to the spinal laminar line. So they may have some central canal stenosis, and this can be fixed surgically. Of course, they have some degenerative disc disease here as well, a little degenerative annular calcification, no big deal. In this example, basically normal, we just have a congenital block vertebra here. Okay, so we've got a wasp-waist deformity, small little rudimentary disc. Facets are fused back here. Looks like our lamina are probably close to fused, if not fused. So this is a normal congenital block vertebra. This is their MRI, and you can see adjacent to that, they do have some degenerative changes where they have disc bulging, which effaces their cord here anteriorly and kind of indents it actually a little bit here at 4-5. So that is causing actually a little degree of central canal involvement. Here's an example of someone, we again started our ADI, and we look up here, and that's, again, we notice the first thing, just even in this neutral position, we look at their dens here. First of all, it's up inside of their frame and magnum, which is no good. And that's because they have occipitalization of C1, right? There should be a space between our posterior arch and our occiput, like we can see in this example, right? This is normal space. And so we look at this, and then we see they have an enlarged atlantodental interval. Their anterior tubercle is kind of somewhat segmented here, and you can see that's enlarged. So going along with their occipitalization, they have agenesis of their transverse ligament. And so you can see their central canal diameter here, if we go from the spinal laminar line back here to the dens, is much smaller than we'd expect it to be down here at C2. So, maybe 30% loss of space or something like that. The rest of their cervical spine is normal. Again, normal thyroid calcification, no big deal. So now let's get into some conditions here. I want to compare and contrast some cases of AS with DISH, so you don't confuse those two. AS, of course, younger age group, more often in men, much more often. DISH, older age, has an association with diabetes. And so we look at this one, we see these tiny little marginal syndesmophytes bridging anteriorly and posteriorly. They're actually going circumferentially around the disc, but we're only seeing anterior and posterior. Their facets are ankylosed as well. And so this is typical case of AS. And then we compare that to DISH, where we usually have this enlargement and to go along with the calcification of the ALL. And so you can see this massive enlargement of the ALL and calcification. So it almost looks like someone just plastered on a bunch of new bone up here, and that's essentially what it is. And we have open posterior elements, maintain disc height. So these are all typical features of dish. If these were ankylosed back here, I could maybe say this is an atypical case of AS, but we're seeing this ALL calcification here, which is really quite thick, and everything open posteriorly. So this is just normal dish. Of course, probably not going to get much movement here if you manipulate them because they're all fused up. Here's another case of dish versus AS, and so we look at this one. All of the facets are ankylosed, which doesn't occur in dish, right? So we look at this case of dish. All the facets are open. We have a little bit of marginal synesmophyte formation here. Looks like it hasn't quite made the bridge, but it's getting close. This one almost looks a little dishy, but this is still AS just because by the posterior elements. And then we look at this one. This case, we have again that very enlarged hypertrophic ALL calcification, which is very characteristic, open facets like we mentioned, but we have to be very careful when someone has dish to make sure we're looking at the PLL, because ossification of the posterior longitudinal ligament is very common in dish. And so we look back here, posterior to George's line like we mentioned, right? So we start up here, normal, go down here, oh, not normal. Okay, so we've got this PLL calcification here. And so, of course, that's narrowing the central canal because it should be this big. And now it's this big because there's ossification of that PLL. So that one, of course, requires further imaging, probably a CT scan, and maybe an MRI to look for the degree of cord compression. And they may need decompressive laminectomy, so maybe a neurosurgical consult would be warranted in this specific case just because of that PLL calcification. Here's another similar example with we have very prominent dish here, and then ossification of the posterior longitudinal ligament. We kind of lose, can't really tell where it ends, but definitely back here you can see there's this large calcific area. They have a little posterior ponicle here, no one cares. And we look at this AS case. This is a case of AS, very classic in the lumbar spine. Cervical spine could be a little bit trickier. This almost looks a little dishy, but this is because he has really extensive degenerative change in this one mobile segment that's present up here. He has another one mobile segment down here, and then has a fractured kind of marginal synesmophyte down here. But these the intervening areas are very characteristic of AS. Okay, so it doesn't necessarily have to fuse every level. It can leave a few open, and those open levels, of course, are going to become rapidly degenerative because they're the only ones taking up all that motion. They become hypermobile. They build osteophytes and get all this hypertrophic change. You could say, well, what the heck? The facets aren't fused in this case. So this guy's quite young, very active. I think he's like a 30-year-old active surfer and things like that. So he's doing a lot of stuff. Facets haven't quite made the fusion trip yet. These ones down here are probably fused. But yeah, he does have a few open ones. And you could say, well, this one looks fused. Well, it looks fused because there's posterior longitudinal ligament calcification. All right, what did I want to show in this case? This one looks normal, just some routine degenerative stuff. So osteophytes can mimic dish a little bit. They can be quite big in the cervical spine in some instances and curl around. And truth be told, they probably do have a little degree of ALL calcification, but it's not that quote-unquote flowing hyperostosis like we like to see. It doesn't look like someone came in with some plaster and plastered the front of the vertebral body. So this is just normal degenerative change, normal thyroid calcification. We got an earring here, and then we got a couple nuchal bones. Again, back here, no one cares. So this one you could say, if the management question was, some bunch of MRI, this, that, the other thing, continue chiropractic management, I would pick the continue chiropractic management. Here's a case of someone, we look down here, ADI, fine, posterior ponicle, no one cares. We come down this posterior vertebral body line, everything looks good. When you get down to here, and there's a retrosthesis, actually. And at that same level, there's a retrosthesis, there's all the sclerosis, and there's destruction of the end plates. So we're thinking something bad. Well, if this were a tumor would destroy bone more so than the disc, because tumors don't arise from the disc. This is disc-centered. It's going equally across both sides. So this is a disc-centered pathology. So we should be thinking in arthridity. No real arthridity attacks the disc other than AS and occasionally RA in the cervical spine because of the uncovertebral joints. But this is infection. This is spondylodiscitis. This is destroying the end plates. This is very destructive. So it has the destructive features of a neoplasm, but it's centered on the disc. So this is infection. All right, so spondylodiscitis. And you'd expect there to be a big, maybe retropharyngeal abscess or swelling or something. There just doesn't happen to be in this case, so not helpful there. But this is what spondylodiscitis looks like in the cervical spine. This would be kind of an intermediate stage. Early on would just be loss of disc height, maybe a little irregularity. Now we've got destruction, complete loss of disc height, and eventually it's going to collapse these vertebral bodies if left untreated. We look at their MRI, which would be the appropriate follow-up, of course, emergency medical consultation. And we can see that they actually do have a fair amount of prevertebral edema, but they also have extension of this infection with the epidural abscess and then a bunch of enhancing tissue back here. This is a contrast-enhanced MRI. So this person needs IV antibiotics and potentially a neurosurgical consult for emergency decompression, because you can see that the cord here is quite compressed. Just another example of spondylolischitis. This one's quite a bit earlier. Like I said, so this one's in the early stages. They're getting loss of disc height. ADI looks normal, right? We follow George's line, right? The focal kyphotic angulation is at the level of involvement. And we look a little bit closer here at the soft tissues, and this person does have a very large soft tissue collection in the prevertebral soft tissues. They have some gas in here, so this is a gas-producing infection, big abscess up here. So again, this person should have an MRI and with contrast and some emergency medical consultation. All right, so let's look at this case. We got a normal ADI up here. Upper cervical spine looks good. Good space up here. No block vertebra. Follow this line down, and everything looks lined up except for we don't see George's line right here. So you draw this line down, and you're like, wait, what's going on here? What's going on here? We got a line here. We got a line here. Where are the lines here? Right? There's no posterior vertebral body lines. That's not good. That means something destroyed it. Could it be infection? If some loss of disc height here, that'd be reasonable. Could it be a tumor? Yeah, it could definitely be a tumor in the vertebral body destroying out here. And we look at the MRI. And that's what we see. We see replacement of this marrow signal. It's not a disc-centered pathology. The disc here looks good, right? If we compare that to our prior one, right? This is all disc-centered. If we look at this one, none of this is disc-centered. It's vertebral body-centered. And but you can see the epidural collection looks similar, right? So we have posterior extension of this mass compressing the upper cervical spinal cord. So this, I think, was a breast cancer. This one is quite a bit more obvious, mixed lytic blastic. We can see a few sclerotic changes with other lytic changes. We lost the anterior C2 vertebral body here, another bunch of ivory vertebra. So this is prostate cancer mets, I believe. Just a couple more neoplasm cases. Again, in this one, we follow George's line down here. Oop, we lost it right here. And we look at C2 vertebral body closer. It should look like this one. It doesn't because it's been destroyed. So this is lytic mets. This one, of course, bad arrow. Much more obvious lytic mets, completely destroyed and collapsed. Disc spaces on either side look relatively normal, so this is vertebral body centered, probably not infection, most likely a malignant neoplasm, which this was. This one a bit more subtle on the X-ray. ADI actually is increased in this case, so that's for cause for concern. We follow this down. That vertebral body doesn't look normal. It should be flat or even a little bit convex on top. So this one's collapsing. This one's completely collapsed. This is a burst fracture. Pathologically, it looks like they pathologically fractured their spinous process as well. And then we look at the comparison MRI. This is a T1 weighted image. Marrow should be fatty. So all these dark arrows, all these dark areas are neoplastic areas of involvement. We can see this is the area of spinous process involvement, which has precipitated this path fracture. And then you can see the other areas. So the quite extensive disease burden in this person for an X-ray that at first glance looks relatively subtle. Okay, thyroid calcification normal. Don't call that abnormal. The only findings here are in the spine. Here's another example from Dr. Beadle of a neoplasm. This one's benign, completely homogeneously dense, rising from the skull. Just looks like someone took a little ice cream scoop and scooped on some vanilla ice cream back here. This is an osteoma, all right? No big deal. The only time these are a big deal is if they compress something that you don't want compressed. So this is an example of another tumor. We look here, ADI is good. We follow this down. George's line's good. They have a little reversal kyphosis, no big deal. Facets here, they're positionally rotated a little bit, so you could maybe get tricked in a bow tie sign, but it's bow tie at every level. So this person just positionally wasn't perfectly squared up. And we look down here at their spinous process, and you can see that we've got a big expansile lesion here. Is that T1, 3, 4, 5, 6, 7, T1. Yeah, that's the T1 spinous process. So posterior element expansile lesion, two top differential diagnoses are ABC and osteoblastoma. All right, what was I trying to show in this one? Looks like this person's in some type of immobilization device. They've got a hangman's fracture here. Okay, so we look at this one, we follow this down, maybe a little spondy there actually. Traumatic spondylolisthesis at C2, most common cause is a hangman's fracture. We go back here to the pedicle pars region, and you can see that there's a fracture across this. There's that stupid street sweeper again. God dang it. My road is not that dirty. So we got a fracture through the pars here. Okay, so we should see a nice smooth area of bone coming back here to the articular process with C3 from the atlantoaxial joint. Here's another example of a case of trauma. ADI, can't really tell that well. We follow George's line down, come down here. Oh, there's a spondy. Okay, so a traumatic spondylolisthesis in lower cervical vertebra is going to indicate some type of facet injury typically. And so we look back here at the facet. We see this one's got some gapping back here. It's widening. Interspinous distance is widened. You know, there's a focal kyphotic change here. This facet has jumped over, so it should be back here. It should be where this one is, right? It should ideally be back like this. So this one's ridden up. So this one's like a little bit subluxed, but this one's straight up dislocated. So this is a unilateral facet dislocation, and this is our bow tie sign. And you can see everyone at the level above this is a bow tie because they're all rotated from here up, and they're all lateral from here down. So, and that's because, you know, this one jumped forward, so all the rest, you know, are intact, so they're going to stick with it. Here's an example of someone who had a hyperextension injury, and we can see they avulsed off their inferior vertebral corner of their vertebral body at C2. So this is, they probably, you know, tore their ALL in combination with this, but that hyperextension back here just, you know, extended their head back the way it's meant to go, and so these just compressed, which they're designed to do, and so this is a one column injury, stable, but probably is going to require a collar for some time. Here's another example, a bit more subtle. ADI looks good, posterior vertebral body lines look good, vertebral morphologies look normal. We look at their, you know, kind of go through and start looking at some architectural changes, and we see that we have a little cortical disruption here. So this person avulsed off their anterior inferior vertebral body corner. This is another extension and teardrop, which is typically in the upper cervical spine, typically inferior vertebral body corner. These people tend to be neurologically intact. So to compare and contrast that, then this person, you know, these are multi-level here fractures, and you can see they're quite a bit bigger. They're involving basically the entire height of the vertebral body. So this person had a hyperflexion injury diving into a pool, if I remember, and they smashed all this up. So these are flexion teardrop fractures. These often have cord injury because in association with smashing the anterior vertebral bodies, these are designed to flex somewhat, but the traumatic flexion will actually tear stuff back here. So these are often 3-column injuries. They go the whole way across. So these people, this person luckily didn't have a cord injury, but oftentimes these people become paraplegics because they have a high degree of cord injury. They often have a posterior subluxation, retrolisthesis, that type of stuff. Here's an example of a flexion teardrop fracture down here. So this person, you can see, right, it looks flexed over the top here. So this is an extension injury. This came down here, smashed this anterior vertebral body corner, and look what happened. They dislocated their facets as well. So this is a bilateral perch facets in association with a flexion teardrop fracture. This is a grossly unstable injury. Neurosurgical consult and MRI. All right. What am I trying to show in this case? Got a nuchal bone back here. You know, some tiny little osteophytes, no big deal. Discites look relatively good. ADI is normal. Everything's lining up here pretty nicely. So this is just a normal variant sesamoid bone. No one cares. This one, on the other hand, compare and contrast these. This is someone who I think took a dive off their motorcycle, little accident. So they had axial compression injury, and then you can see their atlantoaxial joints don't line up here. Okay, so these are moving in opposite directions, which means that ring is not intact. So they fractured their C1. That's a Jefferson fracture. It was normal on every view except for this one. So sometimes this is all you get. So make sure if you get an open mouth view, you look at that alignment. The other thing you might see is a Dens fracture. This one you could get faked out because there is a little loosened line. That's just a mock effect. You can see that perfectly lines up with their posterior arch coming across. So this is just normal. Here's an example of someone who does have a Dens fracture. You can see there's an abnormal lateral tilt to their Dens, little periodontoid widening, which I guess, you know, can happen from head rotation, but their teeth are perfectly lined up with their Dens here, so their head's not rotated. So I don't really have a good justification for why these periodontoid spaces aren't symmetric, because this is a well lined up X-ray, and the Dens should not be laterally tilted at all. It can be a little posteriorly tilted, but not laterally tilted. And in this case, it's actually anteriorly tilted. So yeah, so this posterior Dens should line up with the posterior vertebral body back here, and it doesn't, right? So we'd expect the Dens to come up like this, and in this case, it's over here like this. So this is a Dens fracture, and this is the comparison CT, and you can see that fracture a bit better. The Dens can not unite congenitally. This is an osodontoideum. When it happens just a tip, that's an os terminale. These ones, osteoodontoides, typically unstable, do require surgical fixation in many cases. Here's another one. This one's probably the result of an old ununited fracture. All right, what is this one showing? This one's showing some degenerative unstable arthrosis here. We got unstable hypertrophy. That shows up as pseudofractures in the lateral view, so you don't want to mistakenly call these fractures. That's just because the unstable process is hypertrophying up here, bringing that joint kind of into view on the lateral projection. Same thing down here. Okay, so these are not fractures; they're pseudofractures simply due to unstable arthrosis, and they also have little carotid artery atherosclerosis. All right, here's another case of some pretty prominent unstable arthrosis, right? These things are getting big and degenerative, and they can, of course, cause IVS stenosis. You can take some oblique views to see the degree of that, maybe that little pseudofracture appearance here, but again, this is just a degenerative spine. These are osteophytes on the vertebral end plates. This person's, assuming they're neurologically intact, perfectly fine to manage. They got some button artifacts here from their shirt collar, which you can see they got a big old shirt collar here. Another button artifact over here. How do I know these are buttons? You can look and you can see actually the 4 holes where the stitches go across. But I suppose you could mistakenly call that like a neoplasm. In this example, we see some really prominent unstable arthrosis here, unstable hypertrophy. Okay, we're looking down here. What's our search pattern for the front of view? I go unstinates, right? Check those out. Facets, these are looking pretty degenerative. Those are the main things in cervical spine, but you always want to make sure, and sometimes I do this first actually. So let's get in the habit of let's not look at this first, right? No one cares. We're not going to find much on the frontal view in this other than the degenerative stuff, and probably not going to get a question on that. Let's start in the lung apices. If you see an AP lower cervical, start here. This is where you're going to miss stuff. This is a pancreas tumor, right? Look at this lung apex, nice and clear, right? This is our space. There's no bone here. There's nothing overlying. It should look like lung, right? Sometimes we'll see a little vasculature in here, very subtle. That's what we want to see. We look at this side. This is completely filled in, and I don't see any justification for why it's filled in. There's no artifacts. There's nothing that could potentially mimic a mass being here. This is a mass. This person had a pancreas tumor on CT. Okay, so people get sued for missing this. Chiropractors, no exception. So you don't want to miss this. And this is, I think there's often a case on boards that's like this. So I'm gonna star this slide 3 times. All right. Look at the lung apices first on your frontal projections. Even on your chest, start in the lung apex. You don't want to miss stuff hiding up there, and then the lung hyla is actually the other area. And we'll see some cases coming up. Oh, here's one right now. Okay, so this one from Radiopedia. Again, we see, look at this lung apex. Normal, filled in. Okay, there's a lesion here. It's a pancreas tumor. And it looks like this pancreas tumor, well, it could be a met, it could be anything really. But they have a lesion in the lung apex. Doesn't cause any rib destruction. It can do that sometimes. But what it also can do is, right, there's other stuff coming down here. Their phrenic nerve has to come down here at some point. So these things can destroy or irritate or, otherwise paralyze the phrenic nerve and lead to elevation of the hemidiaphragm. So this is phrenic nerve palsy from an apical mass. Okay, so that's something else to look for. You can have phrenic nerve palsy for other things, right? It can be surgical or any other number of reasons. All right, so that's a good transition into chest. So I'm going to stop this video and record that separately because sometimes when I record too long, the timing of my audio with the image gets off.